Welcome to Treatment of Hypertension. I hope you're having a great day. Screening for hypertension should be done at every visit to the healthcare provider. At a minimum, it should be evaluated annually. Patients are encouraged to adopt healthy lifestyle changes to maintain a normal blood pressure. In 2014, the 8th Joint National Committee released evidence-based guidelines for the management of high blood pressure in adults, including treatment thresholds, target blood pressure goals, and specific medications. These were more robust, evidence-based guidelines that expanded on the predominantly expert consensus-based guidelines of the JNC-7 released 10 years prior. A major change in the JNC-8 was the shift to more permissive higher blood pressure goals. A major contributor to this decision was the ACCORD, with all capitals, ACCORD blood pressure trial, which failed to show statistically significant morbidity and mortality benefits for diabetics when they were treated with stricter blood pressure goals. In 2017, the American Heart Association and the American College of Cardiology released another set of hypertension guidelines that proposed new hypertension definitions and advised stricter blood pressure control due to the mortality benefits seen from the SPRINT trial that was published in 2015 after the JNC-8. These guidelines focused on stricter treatment thresholds, lower target blood pressure goals, and called for more accurate blood pressure monitoring and highlighted the need for lifestyle changes. Earlier this year, the American Academy of Family Physicians criticized the ACC-AHA guidelines for disproportionately weighing the SPRINT trial and not considering the totality of evidence. The American Academy of Family Physicians announced that they would not be adopting these guidelines and would continue to endorse the JNC-8. I personally tend to gravitate towards the JNC-8. I like the 140/90 as the cutoff for treatment. I also like that they start with one medication. I'm afraid to start with two medications, as dropping the blood pressure suddenly or dropping it too low can cause severe and in some cases emergent problems. I will do two meds if they are in their 40s and 50s and their blood pressure is very high. But then, to contradict myself, if lab work has been done recently, I use the atherosclerosis cardiovascular disease calculator, which is part of the recommendation of the ACC-AHA guidelines. Thus, I use a combination of both. There are more potential for initiation of antihypertensive drug therapy. First-line agents for non-blacks include thiazide diuretics, calcium channel blockers, and ACE inhibitors or ARBs. There is inadequate evidence to support the initial use of beta blockers for hypertension in the absence of specific cardiovascular comorbidities. Thus, beta blockers are not first-line medications for hypertension. In addition, other specific factors such as age, concurrent medications, drug adherence, drug interactions, the overall treatment regimen, out-of-pocket costs, and comorbidities should be considered. From a societal perspective, total costs must be taken into account. I like to prescribe ARBs because of the decreased incidence of side effects, especially the dry cough caused by ACE inhibitors. Patients on a fixed income may need to use the ACE inhibitors due to cost, as many of them are on the $4 drug list. Losartan's the only ARB on the $4 drug list. Please note that the thiazide diuretics are not necessarily the initial first-line agent. I actually never use it as my initial treatment unless the patient is Black, as we will discuss next. In addition, thiazide diuretics, especially in high doses, increase LDLs, and they can also cause hyperglycemia. Chlorthalidone is not an actual thiazide diuretic, but is considered a thiazide-like diuretic. I also like to consider the patient's work environment. I do not prescribe diuretics, again, until absolutely necessary, for patients who work outside and are more likely to experience diaphoresis. In addition, many patients, especially the elderly, do not like the urinary frequency that results from the use of diuretics. Thus, adherence and safety may become an issue. Simultaneous use of an ACE inhibitor, ARB, or renin inhibitor is potentially harmful and is not recommended to treat adults with hypertension. In Blacks, including those with diabetes, use a thiazide or a calcium channel blocker. Blacks have high stroke risk. Calcium channel blockers provide better stroke prevention and blood pressure reduction in Blacks versus ACE inhibitors. Thiazides produce better cardiovascular outcomes, including reduced stroke risk, than ACE inhibitors. In all patients with chronic kidney disease, including Blacks, the regimen should include an ACE or an ARB. A shift in thinking about cardiovascular benefits of ARBs will lead to more use of ARBs instead of ACE inhibitors. We're used to seeing ACE inhibitors since they have more cardiovascular outcome data and seemed to have a bigger impact on cardiovascular events than ARBs. And low-cost generic ACE inhibitors have been available for years. But patients in older ACE inhibitor studies were at higher CV risk due to more smoking, less use of statins, etc., than patients in newer angiotensin receptor blocker studies. So the cardiovascular benefit appeared greater with ACE inhibitors compared to ARBs. Now, a new analysis adjusting for these differences suggests that ACE inhibitors and ARBs have similar cardiovascular efficacy in many patients. Plus, ARBs may be more user-friendly. About 1 in 30 patients will stop an ACE due to cough, and 1 in 300 will develop angioedema. But ARBs rarely cause cough or angioedema. Consider the indication to decide if an ARB is a good option. For hypertension or diabetic kidney disease, feel comfortable using either an ACE or an ARB since efficacy seems similar. For systolic heart failure, coronary artery disease, and post-MI, continue to start with an ACE inhibitors. ACE inhibitors seem to show more benefit than ARBs, especially in heart failure. For angioedema, you can switch to an ARB if patients develop a cough or mild angioedema with an ACE inhibitor, but be more cautious with ARBs if the angioedema is severe, such as with airway obstruction. Most adults will need at least 2 antihypertensives to reach the less than 130 over 80 millimeters of mercury, especially Blacks. A general guideline by the ACC-AHA is to initiate with 2 agents if the systolic blood pressure is greater than 20 millimeters of mercury above goal, or the diastolic is greater than 10 millimeters of mercury above goal. As I mentioned before, use caution in the elderly. I typically only start with one medication unless the blood pressure is very high. For patients with coronary artery disease, first-line treatment is with a beta blocker, ACE inhibitor, or ARB. Post-MI, it should be both a beta blocker and an ACE inhibitor unless there's a clear contraindication. The post-MI treatment should be for a minimum of 3 years to prevent ventricular remodeling. A dihydropyridine calcium channel blocker can be added if needed, or a thiazide and or mineralocorticoid blocker such as aldosterone. You can continue the beta blocker beyond 3 years post-MI or acute coronary syndrome for treatment of hypertension without heart failure with reduced ejection fraction. Any beta blocker can be used, but not atenolol. ACE inhibitors can be continued to be used indefinitely. For hypertension and heart failure with reduced ejection fraction, do not use a non-dihydropyridine calcium channel blocker such as diltiazem or verapamil, remember diver. For a beta blocker, metoprolol succinate, bisoprolol, and carvedilol are preferred. For hypertension and heart failure with preserved ejection fraction, we used to call this diastolic heart failure, add a diuretic for fluid overload and an ACE inhibitor or ARD with a beta blocker as needed. I usually have little to do with these drug selections as they are mostly done by cardiologists. About 10% of hypertensive patients seem to be truly resistant, but many more patients on 3 or more meds have uncontrolled blood pressure due to poor adherence or inadequate treatment regimens. Check for possible pseudo-resistance due to poor adherence, poor blood pressure measuring technique, or white coat hypertension. Look for other factors that contribute to high blood pressure. Meds that increase blood pressure like NSAIDs or high dietary sodium. Optimize blood pressure meds by using 3 core blood pressure lowering meds: a diuretic, an ACE inhibitor or ARB, and a calcium channel blocker. For a diuretic, try to use chlorthalidone or indapamide. These have more evidence of improving cardiovascular outcomes than hydrochlorothiazide. For creatinine clearance less than 30 milliliters per minute, use a loop diuretic like furosemide. If a fourth med is needed, consider an aldosterone antagonist, spironolactone, and monitor renal function and potassium levels. Save beta blockers for fifth line unless the patients have another reason to look at one, such as angina, heart failure, or post-MI. Advise patients to take 1 or more of their meds at bedtime if their blood pressure is consistently high in the morning. I always have the patients take their calcium channel blocker at bedtime to reduce fatigue. And then, if all of these don't work, screen for secondary causes such as sleep apnea, primary aldosteronism, especially if the blood pressure remains high with multiple meds. If the patient's systolic blood pressure is greater than 140 millimeters of mercury, or the diastolic pressure is greater than 90 millimeters of mercury, healthy lifestyle changes are recommended along with blood pressure lowering medications. Then reassess in 1 month. If the goal is met after 1 month, reassess in 3 to 6 months. If the goal was not met after 1 month, consider a different medication or titrate the dose of the current medication up. Continue monthly follow-up until control is achieved. When I prescribe 2 antihypertensives, my go-to selections are losartan 50 milligrams and amlodipine 5 milligrams. I have them take the losartan in the morning and the amlodipine in the evening, as fatigue is one of its side effects. Here's a case study applying the guidelines. A 64-year-old woman has a past medical history of coronary artery disease, hypertension, and dyslipidemia. Her only exercise is walking the dog in the morning and evening. She has been prescribed in the past lisinopril and atorvastatin. Her current blood pressure is 138/76. You must confirm the blood pressure. The patient states she's been taking her medicine and insulin this morning. You repeat the office measurement with similar results. She agrees to try home blood pressure monitoring and you counsel her. After 2 weeks, she reports that her systolic blood pressure is consistently in the same range. What hypertension stage is she in according to the ACC/AHA guidelines? She's in stage 1 hypertension. Should a patient with stage 1 hypertension be prescribed an antihypertensive medication? It depends. Not all patients with stage 1 hypertension should be treated with antihypertensives. If the current patient had been untreated at this initial visit, medication initiation would have been appropriate as she has multiple risk factors of coronary artery disease, hypertension, and dyslipidemia. The next step for this patient is trying to intensify treatment. Basically, you have the choice of adding one medication from either the thiazide diuretics or calcium channel blockers. After discussion with the patient, you choose a thiazide diuretic. She needs to be counseled on the DASH diet and exercise, and she will be followed up in 1 month. I hope that you feel empowered with knowledge to treat hypertension.